Good evening, respected Chairperson Dr. Trinokar sir, Speaker Dr. Suresh Kumar sir and delegates. We from Cepheus Division of Sun Pharma welcome you all to special edition of CARISPEC DGM Meet. I request Dr. Trinokar sir to kindly take over the proceedings.
Yeah. Good evening to all of you. I think I must thank the Sun Pharma Cephas. I think Cephas is doing the first meeting now, isn't it? So I think I must thank Cephas for giving us all of us a very important thing, a memorable meeting, so that we can meet at least virtually. Actually, this meeting was we wanted to have it 3 months back itself when they introduced the molecule. But at that time, I think most of our, as man proposes, God disposes. I think many things has been decided by the virus, not by us. So what happens is, so many times it was postponed, and even and once the travel ban was lifted, immediately I left out of India because no other chance. After that also it was a big problem, Omicron, isn't it? So after coming here also, we have all those things. Thanks to the political thing, now it has been reduced. They have given lot of permission. And now we wanted to have this meeting. Somehow the last hiccup is today's South Zone meeting. And the South Zone meeting also made us to postpone. But actually, I'm very happy as well as that delighted to know that myself as well as Suresh got a lot of phone calls when they changed the timings. That shows the interest they are showing in the lecture of or hearing Dr. Suresh Kumar. I think we have been deprived of the privilege of listening to Suresh Kumar for a very long time. Happy that Dr. Suresh, I welcome you to this session. And then I think you can go ahead with this particular molecule, Cariprazine. Thank you.
Thank you, sir. Thank you so much. I'm allowed to share the screen. At the outset, let me thank Professor Trinokar sir for actually personally calling and inviting me for this meeting. And I also want to thank Sun Pharma for organizing this meeting. So this evening, I'll be primarily focusing on treatment of schizophrenia and bipolar disorder. The focus will be on cariprazine. So the outline for today's presentation is, I will have a few slides on what is the shared characteristics between schizophrenia and bipolar disorder, particularly in terms of a treatment response. Then I'll straight away go to cariprazine, the molecule. I'll talk about the molecule, the dopamine stabilizer cariprazine is. And then I'll talk about the role of cariprazine in various disorders, particularly the one that have been approved by FDA, namely schizophrenia, cariprazine.
And now we wanted to have this meeting. Somehow the last hiccup is today's South Zone meeting.
I think, sir, your talk is now coming online.
See, the moderator has to see that what is happening. Yeah.
Can I proceed, sir?
Yes, sir.
Okay. So, in the outline, I'll first be talking about the shared characteristics between schizophrenia and bipolar disorder, particularly focusing on the common treatment response between the two important psychiatric disorders. Then I'll turn my attention to cariprazine, the molecule, the dopamine stabilizer. And then I'll talk about the role of cariprazine in various psychiatric disorders, particularly ones that have been approved by FDA, schizophrenia, bipolar disorder. And then there are also certain disorders in which it could be applied. At the moment, they are not approved. is off the label, but I think we'll talk about the merit of cariprazine as an adjuvant in major depressive disorder. And I'll also talk about in other psychiatric disorders, particularly early psychosis and neural disorders, before concluding. That'll be the outline for today's presentation. So let me first talk about what is the overlap between schizophrenia and bipolar disorder. Many of you would recollect, if somebody has read the textbook by Mayer Grass, which we're very fortunate to read as postgraduates in psychiatry, and then the line by Martin and Slater and Roth would be, by a stroke of genius, Emil Kraepelin differentiated between schizophrenia, which was then referred to as dementia precox, and bipolar disorder, which is then referred to as manic depressive insanity. So Slater and Roth thought it's a stroke of genius on the part of Kraepelin to differentiate between dementia precox, which turned into schizophrenia, and manic depressive insanity, which turned into bipolar disorder of today, as two different forms of psychosis based on a very, very important criteria called the clinical codes of the disorder. Used clinical codes as a criterion to differentiate these two conditions. But genius that he is, he also pointed out at the same time, these two disorders might vary in the codes the way he thought, but could contain some shared characteristics, particularly symptoms could be very common and it could be confusing for the clinician. They include delusions, hallucinations, and mood symptoms being present even in schizophrenia, and hallucinations and delusions being present in manic depressive psychosis. So he was able to differentiate, at the same time agree there could be some similar things between the two disorders. But today we know there is a considerable overlap between the two disorders, which is what many people will question the diagnostic validity of psychiatric disorders. If you look at the two major disorders, schizophrenia and bipolar disorder, they overlap considerably in terms of symptoms, as I said now, and in terms of familial pattern and in terms of risk genes. You see a single family, in the same single family, you have a familial transmission going on for both schizophrenia and bipolar disorder. So the familial patterns could be common, the risk genes could be common, some of the environmental risk factors could be common, and some of the neurodevelopmental factors contributing it could be common. And so the outcome of the disorder, initially we used to be very optimistic and say bipolar disorder carried a very good prognosis and the outcome is very different from schizophrenia, which ran into a downhill course. We do know many other people suffering from bipolar disorder have a very poor outcome, and the functional impairment is also significant in them, causing a burden to the families and other caregivers. And so the treatment response between these two disorders is also common. From the very beginning, I think from the introduction of the first generation antipsychotics like haloperidol, I think predominantly many of us manage with haloperidol. Even today, you can't think of managing an acute mania without the help of an injectable haloperidol. So the treatment response, whether it's the first generation or the second generation, now the current medications, we still tend to use some common medications in both the disorders. While we think about two major disorders as very different diagnostically in ICD-11 and DSM-5, the clinician still finds it very confusing because there are so many overlapping features between these two disorders. Now, first, let me talk about the shared genomics between bipolar disorder and schizophrenia. Just take this. If you take people suffering from bipolar disorder and you look at the familial transmission, this is an excellent work done as usual in the like Nordic countries like Sweden. Kendler, I'm sure you're familiar. For nearly many decades, I think Kendler has been single-handedly working with the genetic association of various disorders, particularly focusing on schizophrenia and bipolar disorder. Kendler was looking at the familial transmission, very recently published in JAMA Psychiatry. He said, if you look at bipolar illness to bipolar disorder in the families, largely the biggest contribution comes from gene with rearing or just genes. So genes are extremely important in transmitting bipolar disorder. Same bipolar people, families can also have some people suffering from major depressive disorder. And there, I think, you need to understand that genes and rearing is very important, but on moderate level. And genes alone may be very little, little more than average important. Whereas some other people can actually transmit schizophrenia. There again, in schizophrenia transmission within the families from bipolar disorder index cases, that genes and genes plus rearing do not have an ordinary impact, they have a moderate level of impact. So obviously, there is a significant overlap. The genome-wide studies have clearly shown there are a lot of, so say, in the genes which are common to both the disorders. So it's a shared genomics between many disorders, between bipolar disorder, schizophrenia, autism spectrum disorder, and various other neurodevelopmental disorders. There's a lot of overlap in terms of genomics. So when we talk about the brain abnormalities, any student who wants to learn about the brain abnormalities of the disorders, when he reads about one disorder, he goes to the next disorder, he gets very confused because they talk about many common pathologies in disorders. This is very true for schizophrenia and bipolar disorder. In both the disorders, the cortical volume and the cortical thickness deficits are critically important. So in almost all the studies that focus on the structural abnormalities of schizophrenia as well as bipolar disorder, there is a common element of cortical volume and cortical thickness deficits being there. And so these pathologies are not only shared between them, but they're also similar environmental and neurodegenerative, neurodevelopmental factors contributing to it. So there is a lot of overlap between schizophrenia and bipolar disorder. Last but not the least, I told you, the treatment response, again, seems to be very common. Looks like it is immaterial whether you are dealing with schizophrenia or bipolar disorder. You can perhaps treat both of them with similar kinds of medication. The earliest observational study that an atypical antipsychotic, particularly a second-generation antipsychotic, will be very useful as a maintenance treatment of bipolar disorder is the use of clozapine in people who are resistant bipolar disorder people. So this is observed the first time, use of clozapine in resistant mood disorders, and people found that it could be used as a maintenance treatment for bipolar disorder. From then on, you all know that second-generation antipsychotics have been used as a maintenance treatment in bipolar disorder, not only in schizophrenia. Now, FDA, for example, has approved number of second-generation antipsychotics for the maintenance treatment of bipolar disorder. They include aripiprazole, olanzapine, quetiapine immediate release, ciprasidone, now cariprazine recently, risperidone long-acting injection as a monotherapy or in adjunct with other antipsychotic medications, and aripiprazole injection as a monotherapy. So all these have been approved by FDA as medications for both schizophrenia as well as maintenance treatment of bipolar disorder. So you can see the treatment response is also common. So I just wanted you to think, even though we have two distinct disorders which have been classically taught all the time from Emil Kriplin's days, still there could be overlap between these two common psychiatric disorders and challenging, burdensome psychiatric disorders. Then I'll turn the attention to cariprazine, the molecule, which is a focus today. Talk about cariprazine. Cariprazine belongs to a group of antipsychotics which are known as partial agonists. I think we are all familiar with the concept of partial agonism, particularly when one of the important partial agonists that we've been using for a long period of time is aripiprazole at this point in time. So in psychiatry, for example, many other conditions, we use partial agonists. Buprenorphine, an opioid, is used as a partial agonist in the treatment of opioid dependence. Partial agonists have become very popular recently simply because cariprazine is a partial agonist. And it is a partial agonist in three receptors, three important receptors: dopamine 2 receptor, dopamine 3 receptor, and serotonin 1A receptor. At these three receptor level, cariprazine is acting as a partial agonist. But at the same time, cariprazine has an antagonistic action on receptors such as serotonergic receptor 2B, 1A, 2A, 7, and 2C. Some of which are very important for pro-cognitive functions. Some of it is important for anti-affective symptom properties. And the histaminic 1 receptor and the alpha-1 adrenergic receptor. These not only contribute to the effects of the medication, but also to the side effects of the medication. Cariprazine, the interesting phenomena in comparison with aripiprazole, for example, is its greatest affinity for D3 receptor. Its D3 receptor affinity is 10 times greater than the dopamine D2 receptor agonism. So if you look at the affinity of this molecule towards dopamine 3 receptor, this is probably what distinguishes it from other partial agonists, for example, like aripiprazole. So what is this partial agonism means and what is it cariprazine does? Normally, this partial agonists like aripiprazole, brexpiprazole, and cariprazine are called as dopamine stabilizers. What do? They exhibit partial agonism, as I said, on the dopamine receptors, aripiprazole only on D2 and cariprazine on D2 and D3 predominantly, and brexpiprazole predominantly on D2 more than D3. But then, what do all these partial agonists do in common? They allow adaptation to the prevailing neurotransmitter environment in the neuronal system. For example, partial agonists can act either as a functional agonist or as a functional antagonist, depending on what the transmitter environment is like. For example, when the dopamine levels are very high, they act as antagonists and decrease it. When the dopamine levels are low, they act as agonists and increase it. So depending on the prevailing neurotransmitter environment in a particular neural circuit that we are referring to, this may act as an antagonist or as an agonist. To give an example, cariprazine is a functional antagonist in the mesolimbic pathways. You would appreciate almost all the antipsychotics that are there in the market today, without an exception. They're all act as dopamine antagonists at the mesolimbic pathway level. That's the reason why you have amelioration of positive symptoms by all these antipsychotics, from the first generation antipsychotics like haloperidol to trifluperazine to the third generation drugs like aripiprazole, brexpiprazole, and cariprazine. All these drugs are dopamine antagonists at the mesolimbic pathway level. That's why they have a benefit in the positive symptoms. But this drug, being a partial agonist, also has a functional agonism in the nigrostriatal pathways, because the dopamine antagonism functions even in the nigrostriatal pathways. They contribute to the iatrogenic extrapyramidal symptoms. That's what happens with other antipsychotics. Whereas a partial agonist like cariprazine acts as a functional agonism in the nigrostriatal pathways, and so the possible development of a iatrogenic extrapyramidal side effects is much less compared to other antipsychotics. That's the physiology behind the partial agonism. Okay, now with regard to cariprazine, this particular cariprazine acts, I said, predominantly has an affinity to D3 receptors, and D3 receptors have a very high affinity for dopamine. I think they are predominantly located in the ventral striatum and other parts of the limbic system. Very lowly distributed in the dorsal striatum, which is the motor striatum, and in the cortical region. This unequal distribution of dopamine D3 receptor and cariprazine being a dopamine D3 preferring partial agonist makes it to exert a potent antipsychotic activity acting at the mesolimbic level, whereas there is a very low propensity to produce side effects like extrapyramidal side effects, which I explained, hyperprolactinemia. For example, if it's going to be blocking on the pituitary, pathways, and then, dopaminergic pathways in the pituitary region. And I think that's what produced product anemia by, for example, drugs like amisulpride, risperidone. That problem is not there with aripiprazole as well as cariprazine. Hyperprolactinemia is not there. Metabolic syndrome, which is commonly associated with drugs like olanzapine and clozapine, is not there. And anhedonia, which is a common side effect of many of these antipsychotics, again, not there. So just the fact that it is D3 preferring dopamine partial agonist, and I think there are some advantages because it exerts its antipsychotic activity, but does not produce some of these unwanted things like extrapyramidal side effects, hyperprolactinemia, metabolic syndrome, and anhedonia. That's the advantage of the dopamine stabilizer, like a cariprazine. So Stahl produces a beautiful animated cartoon in which he explains how this action, partial agonistic, antagonistic action at the D3 dopamine receptor level is going to have a very significant influence of cariprazine. The reason why cariprazine may be potentially useful is possible. It's quite possible to know that if you have a D3 antagonism or partial antagonism at the D3 receptors, which are situated on the somatodendric receptors, and this results in an increased dopamine in the prefrontal cortex. If you increase the dopamine at the prefrontal cortex, that's going to regulate the aberrant cortical activity that is taking place in the prefrontal cortex in illnesses like schizophrenia. That is what is producing the significant negative symptoms and the cognitive impairment in these disorders. So perhaps by increasing the dopamine in the prefrontal cortex through its action on the D3 receptor at the somatodendric receptors in the ventrotegmental area, in the limbic areas, I think you have an indirect influence of it, dopamine release in the prefrontal cortex, leading to a reversal of negative symptoms and improvement in the cognitive impairments. So that's the way in which perhaps this drug is explained, this action is explained, mechanism of action is explained, is by Stephen Stahl way back in 2020. I think in a very well-written article, he just argues and says this drug has this potential to be a pro-cognitive and anti-negative symptom medication. But we don't know how it's going to be translating into the real world in clinical practice. We'll look at it. Okay. Now, very recently, last year, there is this article that was published as late as late 2021. This is a very interesting article because this is a new technology they've used using a nanoscale technology called pharmacostorm. They produced an in vivo evidence that cariprazine, the molecule, predominantly binding to the D3 dopamine receptors on the islands of Calleja, granule cell axons. All of you know in anatomy, neuroanatomy, if you're familiar with that, the islands of Calleja cells are situated in the ventral striatum of the brain and in the limbic parts of the brain. So we still haven't understood the neuropsychiatric significance of islands of Calleja. To me, as a person who is interested in addiction, I know for sure this particular granule cell axons are mediating the reward pathways. Perhaps this will be one of the reasons why this drug may be important in actually working on the reward pathways and helping to reduce the relapse in addiction. And so I think these reward pathways may also play a role in schizophrenia in one way or other. So I think in future, we should be looking at the neuropsychiatric significance of this particular region because as a molecule, cariprazine, we seem to be having a significant binding to this. This new work perhaps will throw some light in the future on our understanding about some of the things. Okay. Let me talk about some of the metabolism of cariprazine. I think as a day-to-day practice, if you're going to be prescribing this molecule, we should be very familiar with how this particular drug acts. Unlike some of the drugs, this drug do have interactions because it is metabolized via P450-3A4. And to a lesser extent, this particular drug is also metabolized by P450-2D6. So cariprazine gets metabolized to two major active metabolites. One is called desmethyl cariprazine. The other is called desmethyl cariprazine. So they are popularly known as DCR and DDCR. So why are we talking about it? First and foremost, the half-life of cariprazine is about 2 to 4 days. And if you look at the steady state that happens in 1 to 2 days and 1 to 3 weeks for the two active metabolites. So one of the molecule may be having a little lesser half-life than the original molecule, namely cariprazine, that DCR, whereas the desmethyl cariprazine has a half-life of 1 to 3 weeks. So essentially, the molecule and its metabolites have long half-life parameters when compared to other second-generation antipsychotics, which generally have short half-lives, sometimes very small, like 3 hours. Some of them go up to 91 days. So if you compare drugs like risperidone, paliperidone, iloperidone, asenapine, lurasidone, olanzapine, quetiapine, cipralizine, and aripiprazole, compared to any of these second-generation drugs and to a third-generation drug like aripiprazole, certainly cariprazine has a very long half-life. So this translates into one single clinical important fact, which is if a drug has a half-life which is longer, it becomes easy to give the medication once a day. So you don't have to split the dose. Often we give medications, for example, olanzapine, we do it, like 2 times sometimes. Risperidone, we split the medication and give. Whereas with the cariprazine, we can actually enjoy giving this once daily administration. Always once daily administration facilitates treatment adherence and treatment compliance. It's much easier for people to take 1 pill a day or one-time pill rather than taking multiple times. So the half-life distinguishes cariprazine from other antipsychotics that which also will translate clinically. For example, if you admit a person, treat a person with cariprazine, discharge him, and then you give him with a dose of medication and send him back home. And after a while, he's not given an appointment for whatever reasons. He doesn't get his appointment, and so he's not able to get the refill. Many times, when you prescribe a drug like olanzapine, they don't get a refill in time, you're going to have a relapse very quickly. Whereas with cariprazine, there is a delayed relapse rate following discharge from a hospital. And they say, relatively speaking, even if 4 weeks, if somebody hasn't taken the medication, the relapse rate will be 5% compared to many other antipsychotics, which can range from 8 to 34%. So depending on the antipsychotic that we employ, after a discontinuation of the antipsychotic, how quickly the person will come back with the symptoms is decided by the type of antipsychotic we employed. So that may be much less with cariprazine because of this half-life being very longer. So what about drug-drug interaction? We know that this has been primarily metabolized by CYP3A4, very few by 2D6. So what is this clinical implication? Because it's metabolized by CYP3A4, we need to look at drugs like carbamazepine and oxcarbamazepine. They can induce these enzymes, and so the effect of cariprazine will be decreased. So you need to double the dose of cariprazine. So this combination of combining cariprazine with carbamazepine or combining cariprazine with oxcarbamazepine is indeed contraindicated. So you'll be very, very careful in giving this medication with other anticonvulsants like phenytoin sodium, phenobarbital, or a medication like rifampicin, which is very commonly employed in India for tuberculosis treatment, and steroids like glucosteroids. So these drugs, whenever you want to prescribe, you need to be very, very careful about dosing cariprazine because the effect of cariprazine will be decreased very much with these because they're all inducers. On the contrary, if you look at taking strong inhibitors of CYP3A4, drugs like erythromycin, clathromycin, which is now very commonly given by physicians, diltiazem, itraconazole, ketoconazole, ritonavir, which is a HIV medication, verapamil, and of course, the common grape juice, grapefruit. All this, we need to reduce the cariprazine by half because they're all strong inhibitors of CYP3 or 4. Whereas the 2D6 inhibitors and inducers, we don't have to worry too much. So no dosage adjustment required for that. So you should concentrate on CYP3A4 drugs that induce like cariprazine will be, effect will be decreased with oxcarbazepine, carbamazepine, and inhibitors will make sure that you have to reduce the dose of cariprazine. So you have to be very careful about drug-drug interaction with these medications. Now, I'm just going to switch. Now that I talked a little bit about the molecule cariprazine as a dopamine stabilizer and its various metabolism and, half-life and dosing and the way it metabolize and drug-drug interactions, I may shift the attention to what is its role? How does it play a role in schizophrenia, for example? Now, I want to say, this is one of my most favorite slides. I always show it in any meeting relating to schizophrenia. This is very fundamental for us to understand. When we deal with the challenging, burdensome, complex, heterogeneous disorder like schizophrenia, please understand there are certain domains we should be looking at very carefully. And we should be trying to improve all these domains. Only then we'll be successful as clinicians. So the compass of schizophrenia comprises of the positive symptoms, which is very easy to ameliorate with the medications that we know. Almost all the antipsychotics we know act in the positive symptoms, right from the haloperidol to current cariprazine. Everything will act on the positive symptoms of delusions and hallucinations. To treat delusions and hallucinations, you have a lot of choice. You don't have to worry. But then there are other equally important domains which probably contribute to the impairment in this disorder rather than just the positive symptoms. Those include negative symptoms. So dealing with negative symptoms is critically important. And then impaired social cognition is something we never talked for a long period of time. That's also very important. Quite a lot of people with the lived experience of schizophrenia have an impaired social cognition. They have a problem with emotional processing. There's this problems with the theory of mind. What do I think you are thinking? It's a very, very important phenomena. The social cognition is greatly impaired in these people. And I think the neurocognitive deficits, I'll talk about it later, which includes executive function, working memory, episodic memory, the top-down cognitive control. These are all very important functions which are usually controlled by the prefrontal cortex and the parietal cortex. And this cognitive impairment is a significant one. And there is a very strong relationship between these domains. It's not they are all isolated domains. Positive symptoms relate to negative symptoms relate to cognitive impairment, they all relate to impaired social cognition. These apart, these four domains apart, there is this mood symptoms, which is also very important, whether it's feeling depressed or socially anxious or general anxiety, all these are very important. Indeed, subjectively speaking, patients with the lived experience of schizophrenia will not be comfortable with you unless you address the affective symptoms. Do whatever you do, unless you address the affective symptoms, they will not subjectively say, I'm happy with the consultant who provided treatment to me. You're only targeting the positive symptoms. Whereas negative symptoms and cognitive impairment can contribute richly to impairment. And impaired social cognition will be very troublesome for social function. So you think you need to understand the complex domains that are involved in schizophrenia. Notable among which is negative symptoms. Ever since, the concept of positive and negative symptoms was articulated by so many authors, like T.J. Crow, Nancy Andreasen, all of them talked about it. But I think this is something which are not able to change the trajectory with our current treatment. This is a sorry state of affairs. If you look at negative symptoms, previously you used to think negative symptoms come towards the end, almost like it is a deficit syndrome that we are talking about. You only get in after periods of long stay with schizophrenia, then you have the deficit syndrome, which only is negative syndrome. Today we know negative symptoms occur throughout the lifespan of schizophrenia. They are there very early on. When the development of schizophrenia is taking place, right from early childhood, I'm saying from birth onwards to infancy and childhood and adolescence, there is a path that is being paved. From then on itself, negative symptoms come. And perhaps one of the reasons why you see people not doing very well academically, you see a history of people with the lived experience of schizophrenia, they'll give you a history. He was doing very well till 9th grade, 8th grade, and then his grades failed, and he wasn't doing very well. You heard stories like that again and again. And so, the negative symptoms and cognitive symptoms have been very, very important in the scholastic backwardness that happened. And I think negative symptoms also contribute to social integration problems. And I think a lot of people are not social and not mingling. They're schizoid, mainly because of the negative symptoms. And then when actually they have the psychotic crisis, even during the psychotic crisis, apart from the positive symptoms, they could have the mix with negative symptoms. And then in some people, it is persistent negative symptoms throughout the course of the disorder, which actually lead on to the deficit syndrome. So you see, negative symptoms are spanning throughout the life of schizophrenia, and they may be actually contributing to the deterioration and impairment in schizophrenia. Not only just negative symptoms, but also the cognitive symptoms are so very important. Again, I'm sorry to say, even now, we do not have medications and other things which can actually target cognitive impairment very well and produce the significant improvement we are looking at. Cognitive factors are critically important, particularly look at attention, perceptual processing, working memory, verbal memory, and the processing speed, all of which are very, very important for somebody to be productive in school, in college, or at work. If you're going to be successful, functioning successfully, you need to have an intact neurocognition. And that alone explains 52% of the variance, whether somebody will get back to school, whether somebody will get back to work. You ask the families, what do they want? When they come with a person with the lived experience of schizophrenia, the question they often have in their mind is not when will the delusions vanish, when will the hallucinations vanish. They'll say, when will my child go back to school? When will my son resume college? When will my son go back to work? When will my husband resume his duty? That's a question that is often asked by the families. So that is mostly contributed by neurocognitive factors rather than by positive symptoms, negative symptoms, and other factors. So I think you are missing a very, very important element, neurocognitive impairment. And I think addressing that is also a challenge with schizophrenia. Now turn our attention and say how much justice cariprazine can do in addressing the domain that I talked about. First and foremost, is cariprazine useful when somebody has an acute exacerbation of schizophrenia? Almost quite a lot of phase 3 trials have done, and all these trials have used a lower dose of cariprazine. They use anywhere between 1.5 to 6 milligrams, not exceeded that. Most of the clinical trials which deal with acute exacerbations have managed to deal with this problem with a dose of 1.5 to 6 milligram of cariprazine. A pooled analysis of all the trials that has happened with acute exacerbations include thousands of people who have been put on schizophrenia, to be precise 1,024, and 442 people taking placebo. They're all done with the PANS. PANS is a clinical instrument. Clinicians don't use it regularly because it takes about 50 minutes to 60 minutes to complete it. So it's not easy to do it in a clinical work, but if you're doing some research or if you're doing to do some rigorous work, that's when you give PANS. And PANS is a very good clinical instrument we use to assess the symptoms. And the mean baseline in these people were about 97. After about 6 weeks of treatment with cariprazine, it reduced by 16.8 points with a dose of 1.5 milligram and reduced by 19.5 points with a dose of 60 milligram. So you see, there is a significant reduction, about 17 points with 1.5, and probably you add 3 more points with an additional 4.5 milligram. So it looks like 1.5 milligram itself is good enough to reduce it by 17 points. So the trial, at least in one trial, the comparative drug was ariprazole. In another trial, the comparative drug was risperidone. In both these trials, the impact of cariprazine on PANS score was not higher than ariprazole or risperidone, was similar to that. So note this point, cariprazine had a very similar effect to aripiprazole and risperidone, not had a better effect than these two molecules that we already employ in these conditions. Number 2, let's talk about cariprazine in negative symptoms of schizophrenia. So this is where our interest is, because as I said, positive symptoms, any drug can be helpful. And again, phase 3 trials are there which study the impact of cariprazine on predominantly negative symptoms. The number is about 460. And these patients have had a very long history of schizophrenia, anywhere between 12 and 13. So they are not targeting the negative symptoms that happen early on in life of the schizophrenia disorder. And I think they're looking at late onset, like after 12 to 13 years, many of them exhibit negative syndrome. And this negative syndrome were usually targeted by this drug. They employed the scale PANS, like factor score negative symptom. And the factor score negative symptom really describes the negative symptoms very well. The average score was about 27.5. And the patients after 26 weeks, I think as I said earlier, the PANS score was improved with, cariprazine, we knew that. But with regard to even negative symptoms, there was a reduction. There was a reduction of almost 8.9 versus 7.44. So this reduction is statistically significant. We don't know whether statistical significance means clinically significant. That's a question that we need to be asking as clinicians. Does statistical significance mean it is clinically significant? It's clinically relevant. So the mean dosage that was responsible for producing this statistically significant reduction was about 4.2 milligram of cariprazine. So 4.2 milligram of cariprazine was employed to show the reduction in compared to, almost a 4 milligram of, risperidone. Now, recently there has been a case series. This case series have become very interesting because, previously journals won't accept case series. Today, people appreciate the clinician and the value of the clinicians, their observations, their astute observations, clinical observations. So this is a case series in which about 3 cases were documented with negative symptoms. And they all have a long history between 2 to 11 years. They have received multiple treatments before they were initiated on cariprazine. And they could easily switch from this previous antipsychotics to cariprazine. They tolerated it very well. After 3 months, after 12 weeks, there was improvement in the negative symptoms. And they also show the negative symptoms have a very significant relationship with global functioning and clinical global impression. We know Stephen Lewis, one of the studies, pointed out very clearly that negative syndrome scales like PANS and a score closely relates to global functioning and global impression, clinical global impression. So the clinicians even documented that there was not only improvement in the negative symptoms, but also in global functioning and clinical global impression, whereas the positive symptoms are quite stable. So the case series helped us to understand. These are 3 case studies, and I think which helped us understand this may be useful in negative symptoms. So currently, there is an evidence that cariprazine may be a favored drug among all the antipsychotics at this point in time, where the person with the lived experience of schizophrenia is exhibiting predominant negative symptoms. It is for clinicians here in the audience and senior people who have used it already to figure out and say whether it is actually true in their clinical experience. Now, let me talk about the cognition part of it. Is it a drug that promises to be a pro-cognitive drug? We talked about so many drugs. When they came into the market, I myself, talked about the pro-cognitive purely based on the physiology of the drug and where the drug acts. For example, lurazidone. We talked about how pro-cognitive, why it be pro-cognitive. But unfortunately, when we actually translate it into clinical practice, it's not working like that. So I think the clinical paradigm is very different than what we see in a biological paradigm. So here with cariprazine, in the trial situation, they found there is an improvement in the PANS cognitive subscale. And almost on each individual item of the cognitive subscale, there was a significant difference in the pooled post-hoc analysis. So this was not actually just a trial data. This is the pooled post-hoc analysis of 3 acute studies that I referred to. And I think from that, the data has been drawn. And with the dose anywhere between 1.5 and 9 milligram, there is a statistically significant improvement in the cognitive functions as assessed by PANS cognitive subscale and cognitive subscales of each item. So there is a possibility that it could be useful in reducing the impairment and cognition in people with lived experience of schizophrenia. So we talked about acute exacerbation. We talked about negative symptoms. We talked about cognition. What about cariprazine in the long-term treatment of schizophrenia? We all know that, like some of the drugs like ariprazole, we can give it many conditions, including for the long-term maintenance treatment of schizophrenia. So we know that we give long-term preparations for the long-term treatment of schizophrenia. Many antipsychotics we commonly use for the long-term treatment of schizophrenia. Can we use cariprazine as a long-term treatment? So it can be seen that it can be studied for the prevention of relapse. There are studies which have been done up to 72 weeks. And I think the relapse with cariprazine is about 25% compared to the placebo group, where it's about 48%. So the relapse seemed to be almost half compared to the placebo group. And so maybe cariprazine is a good drug to prevent relapse among people with the lived experience of schizophrenia. So then I'll talk a little bit about practical issues. And I think cariprazine is currently available as 1.5, 3, 4.5, and 6 milligram capsules. This is how it's available. If somebody wants to have a dose equivalent, this is like Marx's reference. Even the 13th edition has talked about cariprazine. And 3 milligram cariprazine is equivalent to 3 milligram of risperidone. A milligram of, like cariprazine translated to a milligram of risperidone. That's easy to remember. 3 milligram cariprazine is equivalent to 10 milligram olanzapine, is equivalent to 80 milligram lurasidone, is equivalent to 300 milligram quetiapine, is equivalent to 400 milligram amisulpride. That's a rough calculation you have as a dose equivalent. I think it's good to know, particularly when you are switching from one drug to the other. I think we should be familiar with this dose equivalence. 3 milligram risperidone, 10 milligram olanzapine, 80 milligram lurasidone, 3 milligram of quetiapine, and 400 milligram amisulpride are almost the equivalents of 3 milligram of cariprazine. It's a useful way to convert. Now, how do you initiate people on cariprazine? Normally, we start with 1.5 milligram, and we can go up to incrementally, we can go up to 6 milligram. So you start with 1.5, and target is usually up to 6 milligram because most people haven't really exceeded that dose. But then there are two titration strategies. One is called a fast titration. Another is a slow titration. Fast titration is you want to increase the medication on an everyday basis or alternate basis. Where do you do that fast titration? You do it when somebody is exhibiting significant psychotic symptoms, when there are considerable psychotic symptoms with or without negative symptoms. And there are significant weight gain problems produced by a previous medication like clozapine or olanzapine. You really want to shift over. And this is when you have a fast titration achieved, right? So, whereas the slow titration, usually when you do in a long-term study, like you really want to be, dealing with people with predominant negative symptoms. You're not in a hurry to ameliorate the symptoms. They're not having so much of disturbing positive symptoms. Here you can adjust the increments every week till you go up to 6 milligrams. So the fast titration is usually done in positive cases, and the weekly adjustment, slow titration is done in negative symptom predominant ones. How do we switch? Often the question comes, people have been on some medication. Often clinicians will say, how do I give somebody who's already been on a medication? How do I actually switch over to cariprazine? Supposing you have a similar acting drug like ariprazole. I said ariprazole is a partial agonist. So you only require a cross titration. I think we have to remember cariprazine should be given only with cross titration is recommended in all cases. So a cross titration of 1 week is required, where you will take about 1 week to taper off the dose of, like a drug like ariprazole, because it's a similar acting drug. So you only require 1 week of cross titration. Supposing you're changing from risperidone, for example, typical T2 antagonistic drug like risperidone. You want to change it to cariprazine. You are not going to be aggressive in 1 week. You take 2 weeks, because if you suddenly switch from risperidone to cariprazine, you might have a dopaminergic rebound. A dopaminergic rebound, suddenly withdrawing a very powerful D2 antagonist like risperidone, you might have a dopaminergic rebound. It causes psychotic symptoms, dyskinesia, and agitation. We've seen in clinical practice, somebody abruptly stopped the medication, and then there's somebody put on something else, and then they come back with worsening symptoms. Doctor, I don't know what happened. I went to the other doctor for consultation. He changed the medication, and I will have this problem. It's because, like of the dopaminergic rebound that happens in individuals. And the third one, if you want to shift from other medication, particularly clozapine, olanzapine, quetiapine, I would say go at least 4 weeks. Because these drugs, particularly olanzapine, can cause significant histaminergic and cholinergic rebound. You all know, suddenly people coming off olanzapine, they are the ones who are going to be suffering. And it is due to the histaminergic and cholinergic rebound that occurs in them. People become completely sleepless. They throw up, they vomit. And you hear that many times in clinical practice. So I think always remember this overlap, the cross titration is a very important thing. You need to ensure 1 week for aripiprazole, 2 weeks for drugs like risperidone, 3 to 4 weeks for drugs like olanzapine, clozapine, and quetiapine. Okay. What are the adverse effects we'll see with this medication? They are very typical, like any other antipsychotic medication. Like aripiprazole, I think one particular adverse effect which we see, like we're all very familiar with aripiprazole, the one that we see is akathisia. And similarly, cariprazine, perhaps you should be remembering, akathisia may be the commonest extrapyramidal symptom you have. You can have other extrapyramidal symptoms. You could have also, like the Parkinson-like tremor. This could happen. But compared to placebo, many of these patients experience, I remember, the first time I put somebody on cariprazine, and then, I didn't think about it very carefully. I just wrote it, for the night. And then the lady called me up immediately and said, I will completely sleepless. I'll be restless in the night. Then I looked at it and said, oh yeah, this drug certainly produces insomnia. And I think we should be very careful that these drugs in some people, it can produce somnolence in somebody, insomnia in many. So it could happen. So I think you should be careful that in some people, it certainly produces insomnia, way more than somnolence. And it can produce restlessness, and certainly it can also produce weight gain. There is no weight neutral drug, antipsychotic, that we know of. There are no weight sparing drugs. Maybe relatively speaking, they may not gain weight so much compared to a olanzapine or a clozapine. Cariprazine can affect the blood pressure, but it has got a very little effect on the QT interval of the ECG, because some of the drugs have a significant impact on the QT interval, and I think we should be very careful. And cariprazine probably has a little effect on the QT interval. We need to exercise caution in people because, the prescription information says that it should be very careful in people with a stroke. I think we say that all with many of the second generation antipsychotics. We should be very careful. Measurement of lipids, liver function is also recommended, even though we know that they're much better compared to many other drugs like olanzapine. But still, we need to measure the lipids, look at their liver function. Cariprazine doesn't seem to be producing hyperprolactinemia like amisulpride or risperidone. In animal studies, surprisingly, people have found dogs have had cataracts, and changes in the retina have been seen with pigmentation in the in the rats. But I don't know what would happen with the humans. But I think one of the long-term studies have clearly shown, it's a 48-week study. I don't know that it's long enough. And the treatment was generally safe. It's well tolerated. Suresh Dagam, and an Indian American who done a lot of work in cariprazine, and probably one of the earliest person to work with cariprazine and its impact in acute exacerbations and in other issues, Suresh Dagam and his group. And I think they've looked at a 48-week study, and they didn't realize any new safety concerns with long-term treatment. This is something that people have repeatedly figured out. No new safety concern, which we did not see in the short-term treatment, has come up during the long term. And particularly, we are not seeing prolactin elevation, which what happens over a period of time. High levels of sedation or somnolence, these things don't appear over a period of time. Similarly, no clinically significant ophthalmic changes have happened in the long-term cariprazine study, because these particular people, Suresh Dagam people, specifically look at ophthalmic changes very carefully as a parameter and look for it. And surprisingly, they didn't find retinal or cataract or other changes in the individuals with being put on cariprazine for a long period of time. But this is something that we'll be watching over a period of time. Okay, let's just go quickly to other disorders. What about cariprazine? Actually, if FDA has approved it for, mania as well as mixed states of bipolar disorder. So we will need to look at and say, how is cariprazine useful in bipolar disorder? Like, is it going to be useful like aripiprazole, like risperidone? Is it also going to be useful in bipolar disorder? So if you look at bipolar 1 mania, I think this is a summary table from Stahl's paper, but I think there are 3 important studies that have been quoted. One is the Calabrese work, which is the earlier one. That Suresh Dagam's group is the next one. And the Sachs is the last one. They all have employed very similar. At least they've employed about a bipolar mania. They've employed about 3 milligram. Some of them I go up to only 6 milligram. Calabrese have gone up to only 6 milligram. And sometimes it's gone to 12 milligram. And I think every other people have gone to 3 to 12 milligram. Because in mania, you require large dose compared to schizophrenia and management. So they all have noticed, they all used a YMRS scale, in mania rating scale. And the change was seen at 3 weeks itself. A mean change was very, very significant. So obviously, for manic symptoms, looks like cariprazine may be working. What about mania with mixed features? This is a very, very challenging one. When somebody presents with mixed features, which is very common than actually thought about. Previously we thought mixed features were not common. Today in clinical practice, we know mixed features seem to be extremely common. Mania mixed features is extremely common. And I think McIntyre is the person who worked specifically on mania with mixed features. His work has actually made FDA to compile it to give it for an FDA approval. So McIntyre's work talked about mixed features comprising of more than 3 symptoms, more than 2 depressive symptoms, and more than 10 in the Madras score. This is how he looked at various groups, subgroups, and compared to placebo, a dose of 3 to 12 milligram is again making meaningful results, not only in the YMRS for mania, but also Madras scale for depression. So by the rating scales, they could see the mean change was significantly different with the dose between 3 to 12 milligram. So it's useful in bipolar mania. It's useful in mania with mixed features, with both with the dose of about 3 to 12 milligrams. Then what about bipolar depression? Many of you know, I think bipolar depression to me is one of the most challenging disorders. It's extremely difficult to know. It's a controversial topic. We always ask bipolar 1 depression, should we give antidepressants or not? Should we give antidepressants only under the cover of a, a mood stabilizer? But ending bipolar 1 depression, increasingly people are using the 2nd generation antipsychotics for the management of bipolar 1 depression. So cariprazine is no exception. They've tried and seen what is the impact of bipolar 1 depression and cariprazine. Again, Suresh Dargam group, same group, William Early from the same group. And this is a trial done by a company, Allergan company. I think this is from the document and clinical document, and it's available in the Google Scholar. And so these 3, are the ones that are available for bipolar 1 depression. Here, the dose that is employed for bipolar 1 depression is 1.5 milligram usually, and they can go up to 3 milligram. So the 1.5 milligram cariprazine is an extremely useful dose for bipolar 1 depression. In contrast to 3 to 12 milligram, here it is 1.5 mostly, sometimes 3 milligram. So if you look at, using the Madras score, they could see the change at 6 weeks. Mean changes were again significant with 1.5 milligram. I think 1.5 milligram differentiated more than 3 milligram in many other studies, right? So smaller the dose is better for people with bipolar 1 depression. Some people may require 3 milligram. So again, what about bipolar 1 depression with or without subsyndromal manic symptoms? Some of the bipolar 1 depression and also have subsyndromal manic symptoms. Would that be very helpful? Yes, even there, McIntyre's work has shown that it may be useful. So basically, it's not only useful in the treatment of schizophrenia in acute exacerbations, in perhaps with negative symptoms, and possibly, improving cognitive symptoms and in relapse prevention, but certainly it's useful in mania treatment, bipolar 1 mania, mixed features, as well as in my bipolar depression. And I think this bipolar depression may be a little tricky because, whereas some people have said, Dagham and other people have done work and said that this is useful. Lakshminatham, another very, very popular Indian Canadian who works from Canada, I think he's been singularly contributing to a lot of work on bipolar disorders. And he's one of the important persons in the CanMed network. And Lakshminatham was doing a trial with the Cariprazine for bipolar 1 depression. His study has shown that really there is no difference between this and the placebo. So obviously, but the only thing he proved in the study is that it's for a long term, I think it's a very safe drug to use, a very tolerable drug to use, but he didn't find it to be useful for bipolar 1 depression. So there could be, results that could be conflicting between different studies. So can cariprazine be used as an adjuvant in major depressive disorder? For example, aripiprazole, you used, like 2 milligram aripiprazole is usually used as an adjuvant in major depressive disorder, particularly treatment-resistant depressive disorders. It's not a bad idea to have a small dose of aripiprazole, and then that certainly helps people, or even much smaller dose of aripiprazole is very helpful. Can we do the same thing with cariprazine? And I think as an adjuvant, there is a phase 3 trial, and a phase 3 trial by Early et al., which is a similar group like Suresh Daham's group, the same group. They've looked at and said in 2018, a phase 3 trial, really clinically statistically significant improvement was not seen as an adjuvant. On the contrary, Suresh Daham from the same group, he did a phase 2 trial. That's why the phase 3 trial was done. The earlier phase 2 trial indicated that a dose of 2 milligram to 4.5 milligram would be very useful in MDD, which was not replicated in the phase 3 trial by his colleague Early. So there is still this controversy about whether cariprazine can be utilized as an adjuvant in major depressive disorder. Now, what about other psychiatric disorders? Now, I think cariprazine has been used in a case report for non-effective first episode psychosis. I think non-effective first episode psychosis is a big challenge. And I think people have actually used this drug, cariprazine, and found it useful, particularly, and the population that they've used is young people. These are active people, and they are predominantly presenting with negative symptoms. And these people have responded very well with cariprazine. But certainly we require long-term studies to know whether such kind of a subgroup of population like young and active people can actually benefit with this medication in the long run. So this is at the moment not an FDA approval for a first episode psychosis. It's only an off-label. I think people have to figure out and find whether this could be useful. What about, I am interested in dual disorders. So I'm particularly looking at, since I know that this particular drug, cariprazine, has a strong binding through the nanoscale work that I talked about with the island of Calagia in the ventral striatum, which are very closely linked to the reward pathways. I was actually looking for and saying, is there anything I can find with dual diagnosis? Because often people working in the addiction field will realize people have dual diagnosis, particularly people with schizophrenia having a comorbid addiction disorder. And I think this comorbid addiction disorder is a fantastic challenge for all the clinicians because it's very difficult to deal with the dual diagnosis. This is okay to deal with one diagnosis. That itself is a challenging one. And I think dealing with the dual diagnosis is a challenge and what drug to give. So at the moment, I think I've been talking even last week to Konganadu Psychiatric Club and talking about the usefulness of aripiprazole in such cases. And I'm now thinking that maybe cariprazine may be also a useful molecule in dual disorders, particularly because it has an affinity towards this D3 receptors in comparison with D2. And I know that D3 receptors are predominantly distributed in the limbic system. And I think since it's got a significant binding with the island of Calagia, which is very linked to reward pathways, it has a potential to prevent relapse to addiction, as well as got a significant antipsychotic efficacy. One drug acting in two ways could be very useful in dual disorders. I think we need future work to illustrate whether it's going to be useful or not. I'm going to conclude by saying, first of all, I want this august audience to think about the nomenclature we are giving. We are calling cariprazine, aripiprazole, as antipsychotic. It may be very confusing because the same drug is also used as an anti-manic agent. We're also using some of these drugs as an antidepressant. We use smaller doses of olanzapine, fluoxetine combination as an antidepressant. We use small dose of, like aripiprazole as an adjuvant. We may use cariprazine not only as an anti-manic drug, but also have an antidepressant property because of its molecule profile. So are we right in calling these drugs as antipsychotic? Because it can be only confusing. And because we are pigeonholing them into a box and then say cariprazine is an antipsychotic, and then people, outside of psychiatric practice and can confuse and say, you say it's an antipsychotic, but then you're prescribing to a guy whom I sent it for depression. What are you guys are confused here? You don't know how to make a diagnosis. So I think we need to be thinking about a nomenclature. Why don't we use a nomenclature based on pharmacological properties? It becomes much easier, like they do in general medicine. I think why not we call it as a D3 preferring dopamine serotonin partial agonist? That's what it is. D3 preferring D2/D3 dopamine serotonin partial agonist. That's what cariprazine is. So we should call it by its pharmacological property, call it by what it is actually deserves it. So then we will ask whether the effect on D3 receptors is very important. Is it the unique one, or is actions are a class effect that happens with aripiprazole and brexpiprazole and everything? So we don't know at this point in time. This is something that future research has to tell us how much the affinity towards the D3 receptor is actually going to make a clinical translation. Is something we need to understand over a period of time. Cariprazine, we know at this point in time, it has got a brightening and motivating action on the depressed patients. It's got an anti-anhedonic, anti-negative symptom profile reduction in schizophrenia. So these are the advantages. So perhaps we should rename these molecules not just as antipsychotic, but as D3 preferring D2/D3 dopamine serotonin partial agonist. That way we're better off. I will also want to throw up some practical questions to people over here, which has been raised in the Australian prescription, like a journal. Very important questions. I think it's relevant. The first one I've been talking about. We know if cariprazine has a distinct advantage over other molecules is because of its higher affinity to D3 receptors than to D2 receptors. But we are really not very clear whether this so-called clinical translation will occur. So I think it's biologically plausible to think this might have an impact on negative symptoms and have a pro-cognitive effect, and maybe having a, influence on the rewarding pathways. But we are not very sure whether it really truly translates into a clinically relevant effect. This is something people as clinicians have to use it and figure out in the long time. That's a practical question. You keep it in the mind. Second, if we know the cariprazine has improved the negative symptoms in the trials, that is why it's been given approval. But if you look at the difference between cariprazine and risperidone, it's only 1.5 points. That's statistically significant. That difference of 1.5 point in the scale is statistically significant, but I don't know whether it's going to be clinically significant. That small reduction, will it actually make a big difference to the individual and improve him and send him back to work, is a question that I want to ask. We need to figure out. In the short term, cariprazine is no different from aripiprazole and risperidone in having an impact on positive symptoms. So what is the advantage? People should ask and reasonably ask. And then I think we need to ask an important question. It takes about 5 days to 7 days for the steady state concentration to reach with cariprazine. So I think this cross titration becomes extremely relevant when you're shifting from one drug to the other. You can't abruptly stop the medication and start on cariprazine. That's something that you need to remember when you're prescribing this medication. Lastly, there are some advantages with other medications. I can start on olanzapine and shift over to an intramuscular long-acting preparation. I can start on a paliperidone or a risperidone and go to a long-acting preparations of risperidone or paliperidone. And potentially in the future, I can go back to a long-acting aripiprazole also in this country if somebody comes with a depart preparation in this country, which is available in other countries. So what about cariprazine? We don't have a long-acting. So we can shift it to another long-acting after a oral medication with antipsychotic. Those are the practical things that we need to be considering when we are going to be using cariprazine. Lastly, I want to end with this very sober thought. This is an article by Berman, like an Indian, again, who published in the World Journal of Psychiatry. And Berman's argument is, we have new antipsychotics like cariprazine, brexpiprazole. And I think, are they a pledge? It's going to make a big difference to us as clinicians? Or is it another unkept promise, like the way many other drugs have been? I don't want to be mentioning. Several drugs have come to the market and run away in no time. Asenapin, I don't know where the market is. I don't know about iloperidone. Useful drugs, but we not really have a sustained market. We still go back to this risperidone, olanzapine, aripiprazole, clozapine, and I think amisulpride. So why? Is it a pledge or another unkept promise? It's something that we need to be thinking. I believe the way forward is to compare drugs like cariprazine head on head with other drugs and to say, what is this advantage over existing antipsychotics? Only then clinicians will be very convinced that we have a molecule which is significantly better than the existing ones in A, B, C. With that sober thought, I'm going to end it. I'm happy to take any questions. And Dr. Tirunavkar is here to use this molecule extensively. He probably also can give his experience on what he thinks about this molecule. Thanks very much for the listening. And I'm happy to answer any questions and clarifications you have.
Thank you, Dr. Suresh. After a very long time, I'm listening to you. I'm very, very happy that you have brought the cariprazine so palatable to all the audience. It's very nice. I think we will go ahead with the questions. Most of the questions asked is whether how much it is useful with schizoaffective, because that particular word was not used by you.
Kasanin was a person who coined the word schizoaffective disorder. And I remember my famous colleague, Dr. Murugappan, a close friend, used to always tell me, I'm not offending anybody with anything by the word that you used, but I think it is a useful concept. I was asking whether it is a donkey or a horse. They came up and said, it is a zebra. So I don't know what schizoaffective is. Sometimes it's very confusing because if somebody has characteristics of both disorder concurrently occurring in the individual over a period of time sustaining, then you make the diagnosis. And then I think fundamentally, the treatment of schizoaffective hasn't been very different from, how we have been managing schizophrenia or bipolar disorder. So I don't know, because there are no data that I could access which actually talk about the schizoaffective, because it's not a diagnosis it's talked about in research literature as much these days. And I think people like to call it as separate ones. They understand the overlap in any case. And I think there are days in which, I think there were times in which schizoaffective was a very popular diagnosis. I remember in Indian psychiatry, there was a Dr. Raju, a very famous psychiatrist who died in Central Institute of Ranchi. And I think he had written prolifically in this country on schizoaffective disorder than anyone else. And I think, but I'm not hearing so much literature about schizoaffective disorder these days. I don't know, people have lost interest in that. So my thing is, since there is no trial data, and I don't really think I can answer on that. And I do not have, I don't actually make a diagnosis of schizoaffective so easily. I either tend to, fall on one way or other, rather than sitting on the wall, edge of the wall. I like to jump onto one side or other and then, take my, bet on it. It doesn't matter actually in terms of treatment. My good friend, Dr. Kumar Babu used to say, one good thing in psychiatry is, it doesn't matter whether it's schizophrenia or bipolar disorder. You can give the same drug and you'll still be safe and nobody will question you. And so that's the beauty of it. That's a savior for you. So I think I will manage, and I would say, why not? Why not try? You can try. I don't think it's going to be wrong trying cariprazine with schizoaffective disorder, but I don't have a data to back it up. I don't have a clear clinical experience with this particular subpopulation because I'm even wary of making a diagnosis so easily. Sorry about a long answer, but I think that's what I think it is.
Oh, because I think because it is useful in schizophrenia as well as in depression or affect, people might think that this can be very usefully effective, means you can call that disease as a schizophrenia. That is the best way. Then there is another question, that is there any response related to Indian population?
Sir, you must answer that question, sir. You have a vast experience related to me.
Yeah. Then another important question people have asked is it they have any addictive potential? Because you talk about the islands.
That's a very interesting question, sir. People like me work in the field have realized, people who have been put on aripiprazole, for example, for a long period of time, interestingly, a small number will come back to you and say they become very impulsive. They suddenly started to do, like shopping, for example, online shopping. And initially I used to ignore this. And then I have suddenly gone into online gambling. What is this? And then when I repeatedly heard it, I went back to the literature and started searching. And I realized, yes, perhaps because of its rewarding propensity, this itself could excite them to seek new rewards, right? Because it's a partial agonist after all. But then you have to look at anything with a large number, how much people benefit rather than not benefit. If you only use side effect as a criteria, you will not use any drug. You use effect and efficacy as the more important criteria than a side effect. The number of people who would benefit with this drug, even actually reducing the propensity towards addiction, is greater than people becoming addictive, right? So I would say the same might apply to cariprazine. And so people might have some experience of doing something like a gambling or online shopping or whatever. But I think that potential may be there. It's not been explored actually as its medication. It's been explored with aripiprazole. But I think since I have a similar, actions, I would say this could happen because they're all fundamentally acting on the dopamine and then releasing the dopamine, which is actually the one that people enjoy, right? And so obviously, its potential effect on the dopamine release in certain specific areas can make it rewarding. But I think I would really ignore it. I would say its potential for treating it greater than, being an addictive drug. For example, quetiapine is much more dependence-inducing, in my opinion, among antipsychotics than many other drugs. And I think people, my clients, I dare not put them on quetiapine. And a lot of patients will come back to me and say, you know what, I enjoy your quetiapine. I'm tripping on it. I said, I made a mistake here. So you never know. You have to be very careful with your profile of population and then you deal with it accordingly. Cariprazine is early days, but I'm not terribly worried about it.
I have seen people who was very much addicted to anticholinergics. You stop Pacitate, I think they won't accept.
They'll throw a fit. They'll kill you.
Yeah. Then is there anything related to the pregnancy and old age, special population?
No, I don't think there's enough for me to comment on it. It's a drug that's been there for about 3-4 years. Many of these drugs we'll come to know about its use. It's certainly not a drug it's not I think lurasidone is the only drug which probably has this different classificatory system among antipsychotics. Don't think any other drug enjoys that status. So I would actually at the moment wait and watch for what would happen with cariprazine. And I think it'll be too early to say. You would follow the rules and say I will not prescribe it. And I think older population, again, we don't know. I think it's been mostly tried. If you look at, there's a beautiful slide which I wanted to show. It's a long slide, so I didn't take it. Stahl's, I loved that slide. There's a comparison between aripiprazole, brexpiprazole, and cariprazine in terms of indication. And you'll say a long laundry list for aripiprazole. Then compared to just one or two, one for praziprazole and two for, like cariprazine. Only because, not because these drugs are aripiprazole superior to this. It is simply because where the time is. Aripiprazole has been there in the market for such a long period of time. So it's really been used in adolescent, old people, like children with autism. So many, like the indications have come in. I'm sure any drug used after a long period of time, only the indications will increase. Right now, it is premature to say. I think people in India will tell us very soon. They will not wait for all these guidelines and things. They will use it in any case, and they let us know whether it's going to be useful or not. I mean, many people sitting in this audience will actually experiment with older people and then come to realize what's good or bad. But I think it should be a little bit careful in the beginning because we shouldn't burn our fingers unless there's enough experience with that.
I think in elderly, I think we need not worry because this doesn't very much disturb with the metabolic as well as the cardiovascular thing. I think they can go with, and the dosage also very small can be done. Because another question we have asked is, can we use these things in resistant schizophrenia?
That's $1 million question because, like, as I said, the trials have shown that this is equivalent in alleviating positive symptoms like risperidone and aripiprazole, and not better than that. And then the only advantage is on the negative symptoms. Presence of negative symptoms, would you call it as a treatment-resistant schizophrenia? Certainly no. So that's not the definition of treatment-resistant schizophrenia. So I think there is a problem with our, like thinking is, whenever a new drug is introduced, you always believe this should be given to those people who are not, had a response with other treatment. I would actually look at it and say, what is the potential advantage of this drug over the other drugs? Not exactly it's going to be more efficacious. Is it going to be better in some side effects? Is it going to be better in terms of, certain subgroup of population? Is it going to be? Here, I would say, reading the literature, what really strikes is anti-negative, rewarding, antidepressant property. That is what is attractive. His ability to intervene with affective symptoms, his ability to intervene with negative symptoms, and potentially with cognitive symptoms. That is what the subpopulation I will try. Rather than trying it for people who failed with other drugs. That'll be a wrong strategy. Then probably the drug will fail. We'll fail the drug rather.
Thank you for your nice response also. I think now I will go with the my views about all those things. I think, can we put my slides, Ansari?
Yes, doctor. Yes, doctor.
Yeah, because Suresh has started with schizophrenia and even the bipolar and mood disorders later on. I started to go with the first one because many questions are there. Next. See, what happens is, next slide. See, what happens is 70% of this time spent unwell because of the depressive symptoms. In bipolar disorder, we are all worried more about manic symptoms. But when the depression comes, I think even the caretaker or the other people also doesn't give much importance. But the patient is suffering more because of the depressive symptoms. But manic symptoms, the other people suffer. because I used to say the two-dimensional one, because of the mood, who suffers, either the individual or the others. 70% of the time spent unwell with the depressive symptoms. So what happens is it leads to longer-term dysfunction, worse psychosocial impairment, more lost work productivity, worse cognitive impairment, and diminished quality of life. Next. So another problem with the mood disorders is 50% of the individuals with bipolar disorder seek treatment during the depressive episode. They come for treatment. I'm not happy. I'm not comfortable. But when the mania, people are being brought to us. So when the individual suffers, they seek treatment during a depressive episode. So what happens is most of the bipolar disorder, misdiagnosis happen. That is the biggest issue in related to the management of the bipolar disorder. Next. So what happens is the first diagnosis is unipolar depression. So initial misdiagnosis happens in bipolar disorder. So what happens is you put them on antidepressants and it goes into mania. So this is the one problem with the misdiagnosis. So 20% become subsequently experience manic as well as hypomanic episode. Next. So antidepressant monotherapy is not at all recommended for bipolar depression. That everybody knows very well, and everybody has experienced that particular bad experience. But misdiagnosis of MDD is especially problematic. That we have to keep it done. When people, you think in terms like that, then most probably you need some other potential, because your first experience should be best experience. If the patient comes to you and people see that the onset of mania is worsening because of the treatment, that is the problem in the clinical practice. Next. So what happens is most of the drugs approved for depression is quetiapine, lurasidone, lithium and valproate, and combination of fluoxetine with olanzapine. These are all the drugs being recommended by these type of things. The problem with these type of drugs is, see, most of these, actually Dr. Suresh mentioned about asinapine, lurasidone, all those things. See, these also have the same type of pharmacological actions. But what happens is asinapine lost, because in clinical practice, most of my patients told that asinapine means it is sublingual. It's very, very difficult to put the patient on sublingual. That's not at all possible. Another one is lurasidone. Lurasidone is also a very good drug. But what happens is, because of the lurasidone, you would have to take during the food, in between the food. I think that is also very difficult to administer. And the efficacy is only about 160 milligram or so because of that. Next. In this particular thing, he has quoted about what is the rate of discontinuation due to adverse effects with cariprazine. You see, the cariprazine with 1.5 milligram, it is 4.5%. 3 milligram, it is 5.5%. Almost, it's not a big deal when compared to the placebo. Next. So what happens is, cariprazine is a new second-generation antipsychotic. I think Suresh will not accept that word antipsychotic for the treatment of bipolar disorder. But as well as for schizophrenia, and an adjunctive agent for the treatment of major depressive disorder. I think now we are going to get a Sarvanoka Ribanani in psychiatry. Only three diseases only we deal with it. One is bipolar, another one is schizophrenia, another one is major depressive disorder. But most of the literature, except that Suresh Dargam one, as well as my personal experience, it does not have much deal in major depressive disorder. Now there is going to be a drug which is useful in bipolar disorder and schizophrenia,
but not in major depressive disorder. So I think very well, most probably we can call this drug, because everything now has to come under the rubric of psychosis. Next. So what happens is, it is a good treatment option for the patients with bipolar 1 depression. Next. There are so many drugs are available for manic episode. All the antipsychotics we can do, even if you don't treat, the mania subsides after about 3 to 6 weeks. Maximum is sometime 8 weeks. But there is very, very few treatments for depression, especially in bipolar, because antidepressants cannot be prescribed. So the other drugs, which I told the difficulty in other drugs. So most of the patients we tried with lirasidone now, as well as quetiapine, it produces another problem like sedation and weight gain. So only cariprazine and quetiapine is approved to treat both bipolar 1 disorder, mania, as well as depression. Next. Then coming to the bipolar mania. Mania, usually I consider that as very, very easy to treat, because we can use any drug and curtail the problem and it becomes all right. Then coming to this schizophrenia. Next. Now the schizophrenia is mostly called as a neuropsychiatric brain syndrome. So it involves the whole brain. So we have different type of symptomatology. It is not one. See, previously we thought it is only the positive symptoms, the negative symptoms, and cognitive symptoms, everything depending upon the area of effect, or area which has been mostly involved, the area with the other comorbidities. I think you have got these type of things. Positive, I think you have enough literature how to control, or it disappears once the case becomes burnt out. But negative, we have two things. One is primary as well as the secondary. The negative persists, that what happens is the disease burden, poor social, occupational functioning. Now the recovery is based not on the symptoms of positive scales. Even people can live with hallucinations and delusions, but they cannot live without a functional recovery. High levels of unemployment happens because of this poor social and occupational functioning. This is now going to have increase the disease burden. That is how this particular cognitive, as well as Suresh has very nicely explained how these cognitive as well as the negative symptoms affects the whole process. Sometimes even negative symptom itself can produce some positive symptoms. So cope with the negative symptoms, they become positive, like abusive, assaultive, all those things also. Next. What are all the things which is necessary to know about all those things? These are all the things. Negative symptoms is blunted affect, emotional withdrawal, poor rapport, passive social withdrawal, or lack of spontaneity or flow of conversation. Actually, I consider, some of the studies also, they have considered that most affected problem in negative symptom is blunted affect. Nariya பேர் they say that அது என்ன எந்த விதமான ரியாக்ஷனும் இல்லை அவன்கிட்ட. That is the main problem. Even I used to discuss with my students that you say that it is a thought disorder, schizophrenia, but what is the problem is finally we couldn't get the affect. That is the mood. Whether we have been wrongly telling that schizophrenia is a thought disorder, but finally end up with mood disability. The same way you talk about mood disorder, then the treatment, latest treatment is changing the thought process. That is the cognitive behavior therapy. So I think, are we hooked up with these particular terms? The blunted affect, passive or apathetic social withdrawal, and lack of spontaneity or flow of conversation. Now with the current lifestyles, we need this spontaneity and you must have a flow of conversation. Otherwise, you cannot get fixed with it. I think most probably this may be possible when you start work from home. But when you go to the other things. These 3 points are very, very important in the negative things. Actually, certain studies concentrate on these particular 3 factors. They say that whether it can be improved by a particular treatment. Even Cariprazine also, they have done some studies on that. Next. Then nowadays, the efficacy is based not on the scores, it is based on the number needed to treat. 2 drugs which is now discussed related to cariprazine. One is aripiprazole. Suresh has told aripiprazole has got a long stay. Now the cariprazine. The NNT for cariprazine 1.5 to 3 is 6 and 4.5 to 6 is 3. You know very well what is NNT and NNH. But aripiprazole, it is 1.9. So definitely the cariprazine has a more clinical efficacy and clinical usefulness. Next. Cariprazine was effective in treating negative symptoms, but I am worried that whether it can be useful with positive symptoms. I think the most of the literature from US drugs and other things is because amisulpride is not available in US. The D3 is mostly available with amisulpride. I think we use a lot of amisulpride in managing schizophrenia. That is the reason why I think it comes very late to India. And cariprazine is the one which they've used maximum here because D3 is only related to this. If amisulpride is compared with these things, I think that will be a better study where Sun Pharma should take up this particular scientific study, how to compare cariprazine with amisulpride with particularly in schizophrenia. Next. The primary efficacy parameter, what Suresh told you, is because of the half-life. So many times even the patient misses. For example, the clinical practice, we say that what is the best thing is people take the medication. If they stop for a couple of days due to non-availability of the drugs or some busy schedule or something like that, if they don't get into any problem, the non-adherence becomes a problem. But here this doesn't happen. The mean half-life, even certain things I have told that it goes up to 12 because the didesmethyl goes up to 12 days. So you can even say that most probably if you use it once a week, really establishing that some protocol or some studies, then that is a better one. Once a day is a very, very advantageous related to cariprazine. Next. Then adverse effects. What happens in adverse effects is what the literature says is this akathisia, all those things. What I have seen in my patients is akathisia is very much there. There is no doubt at all. All the other things are with even placebo and any drug you change, this vomiting, dizziness, diarrhea, sedation, vision blurred. These are all with any type of molecule you change from one to other or you start. Patients are usually used to say it includes for the placebo also. But one thing which I am specifically seeing with this drug is pyrexia. Some patients says that see, in thyroid or endocrines, they used to say, that's after exercise, it is something like suda. These type of things they say, I think that we would have to keep it in mind. But the literature also mentioned that there is a certain amount of pyrexia. All the other things will settle down. The akathisia is the one. Another one is pain in extremity. Immediately starting on the 3rd or 4th day, especially women, they say that these type of things they say. Next. There doesn't appear to be clinically relevant observations related to prolactin as well as the QT interval. This is a very big major advantage. Many times I think our fellow physicians complain about certain things. Anybody with amisulpride or go with drugs like risperidone, immediately they take a prolactin level and they say, oh, this much of those things. These things, as they say, that claim. Still, I am waiting to see in my cases also, but ECG is quite not threatening at all. Next. So another important thing is, just like your fluoxetine became popular, you see those days the antidepressants like amitriptyline or imipramine, you would have to use to the 25 milligram you start or 50 milligram you start, go up to 250 or so. But fluoxetine, the initial dose is a therapeutic dose. That is 20 milligram capsule was used. That is how it had a breakthrough. That was my opinion. The same way, cariprazine is effective in 1.5 milligram also. So milder cases or soft cases, I think it is a therapeutic dose. Because of this, it is generally well tolerated. Next. Next. And sorry, next. So it is a, previous one. See, previous one. Before that.
This one, doctor?
Yes. So what happens is, no, this one. Yes. It is definitely a treatment drug though in a symptom domain that has limited treatment options. So definitely the most important thing which I see is in schizophrenia, chronic cases of schizophrenia, they say, see, when I put my patients on these things, I say my way of doing is I don't practice this crossover, because I had a very bitter experience with crossover, all those things. So nowadays, I don't see first cases also. I see only cases, the chronic cases. So what happens is you would have to stop all the drugs. They are ready to obey for that or oblige. Then you restart freshly. Then there is no problem at all. It is definitely a treatment breakthrough in a symptom. One patient has told that, அப்படியே பிரைட்டா இருக்கு டாக்டர் மூளை அப்படின்னா. See, that amount of dampening of the inside the brain was relieved by starting this drug. But is it continuous? That you would have to wait and see. It's only a matter of 3 or 4 months experience. Next. See, now in my center, the number of strips being sold so far is, I have mentioned, 1.5 milligram, 280 strips, 3 milligram, 250 strips, 4.5 milligram, 130, and 6 milligram, it is 150 strips. Most probably we start with 1.5, but most of my cases, even if there also you have seen schizophrenia, mania, you go with the higher doses. Depression, you go with a smaller doses. But in mania, I would have to cross my fingers that still I have not followed it for a long time. Whether we have started with good one, and none of the mania cases of mine is not with monotherapy now. Most probably they may improve with other drugs in addition to this, or we have to stop it and see that whether they don't relapse. Depression as well as schizophrenia, definitely this is a quite useful drug, and I have gone up to 12 to certain cases, but I have the maximum cases in my counter is 9 milligram. 6 to 9 milligram is the things, most of the cases. Next. Another things I have taken about what are all the statistics from Tamil Nadu. The number of prescriptions is about 250. Prescribing psychiatrist is 147. So that clearly shows that only 1/3 prescribe the maximum and 2/3 only prescribe minimum. Mostly prescribed prescriptions are only 1.5. Less prescribed are 3 milligram. But I prefer only 6 and 9 milligram. It depends upon the case. Most of my cases are somewhat waiting for a long time to improve all those things. But here what I try to say to all of you is, one thing what Suresh has mentioned, the drug-drug interaction. Most of the adjunct we use in bipolar as well as in schizophrenia is anticonvulsants. See, most of the times you prefer to use carbamazepine. Nowadays, I think nobody uses the carbamazepine drug. Many people use carbamazepine or the sodium valproate. How it is going to affect in the dosage received, that we would have to wait and see whether it has no mention about valproate. There is mention about this carbamazepine and carbamazepine group of drugs. Whether it is going to interfere, that we would have to keep in mind both, because most of the cases, what our teaching is, when it doesn't respond, you start on some adjunct therapy with anticonvulsant. That we would have to do that. Another thing is this. What is the role of this drug? As nicely as Suresh has put it out, see, this drug doesn't replace any drug. That we would have to keep it. You see, we have used haloperidol, we have used risperidone, we have used even the risperidone. The trial was I am also one of the participants of the Indian trial. Everything we used, but still the comparison is only with those drugs, not with the newer drugs. Especially, I don't accept that when it is compared with quetiapine. Now, I think this particular drug is mainly compared with aripiprazole. In that way, I'm happy. That too, aripiprazole 10 milligram is not sufficient. I think we would have to go more. Most probably, yeah, Suresh has put drug equivalents. I think most of the times, aripiprazole 30 milligram, depending upon the conditions. So you would compare like that, most probably it may be an equal drug. But then why a new drug? See, those days, when the drug is being launched, I used to say that getting a new hit is getting married. When newly married, you look so bright and beautiful. But after 1 year, 2 years, 3 years, you look for some other molecule, isn't it? The same way you are looking for it. What is the advantage of this particular thing, these medicines is, see, what haloperidol we have used so long, we have used for so much, trifluoperacin so much. Now Narsala says that it is a neurotoxic drug. See how difficult to accept that, isn't it? The same way the anticonvulsants people used was phenytoin and gardinol. Nowadays the neurologist says they're all not dirty drugs, isn't it? The same way the new schizophrenics, forget about the old schizophrenics, which we have tried for a long. That is what we nowadays we call about drug treatment resistant, all those things. It is not like that. Already the damage has happened. Certain things become irreversible. So you try to do other type of thing. That's what I used to tell my patients. The drug will only control the disease part. Drug will only interfere with the neurotransmitters. But making functional is only by the non-pharmacological methods. So in that way, definitely a case which has been already managed by you, you don't expect a miracle with this drug. But a new case, a prodrome, the Suresh put that particular slide, where nowadays the negative symptoms start first. Those cases you try, I think they will have a good QOL, quality of life. Nowadays, the dictum is mainly you would have to live with all the diseases, including from not only from the Omicron or COVID, you would have to live with schizophrenia, you would have to live with bipolar disorder, you would have to live with the OCD. The same way, a new occurrence of cases, I think our people should think in terms of using new drugs rather than settling with immediately with some other methods. I think reducing a symptomatic relief is different from making the person to improve on functional recovery. As he has rightly put it, delusion is not at all a problem. Hallucination is not at all a problem. This cognitive and social functioning is the most important. In that way, I think this drug will have a place in future. Next. Next. Thank you. And another important thing I wanted to tell this regarding this meeting, the number of participants is crossed 200 today evening, which is a very good number for a Zoom meeting. In that way, I congratulate the efforts put by the things as well as the crowd pulling speaker, Dr. Suresh Kumar. Thank you. Yes, hand over to the Krishna Kumar. Yeah.
Sir, do you want to take any other further questions? Are there, sir? Anything that you would like to answer?
Is there any other further questions? I think I have summed up all the questions. Because all those things he has answered about drug equivalent, side effects, adverse effects, all those things, role of cariprazine in mania, everything. The one thing is the special population, one question not thing is autism. They are talking about autism in this case. I think it is too early to say about the role of this drug in autistic disorders. Suresh, anything else you want to say?
No, sir, I think I was just telling with regard to the drug-drug interaction, sodium valproate may be the drug that we want to give along with cariprazine in the case of bipolar mania, because, like the CYP metabolism of valproic acid is entirely different. And partly, I think what is responsible is only 2C9. So, which is nothing to do with the cariprazine molecule. So, I think it'd be maybe the judicious one to combine is with sodium valproate or even with lithium. I don't really think carbamazepine and artemisinin are only two drugs that are not to touch. They actually even provided us in contraindication. Rest of the mood stabilizers would be happy to use, sir. I think you brilliantly summarized everything, so I really have nothing to add.
Thank you.
So once again, good evening to all respected doctors. We from CFS Division of Sun Pharma wholeheartedly express our sincere gratitude to our speaker, Dr. Suresh sir, for excellent elucidation of cariprazine and answering all queries. We thank respected Dr. Tirunakar sir for taking time out from USA for chairing the meet and sharing your rich user experience. And to all respected doctors across country for gracefully attending our Carispect meeting on this Sunday evening. Thanks again, once again to all. Shubharatri.
Thank you. Good night.
Thank you, sir. Thank you.
Thank you, sir.
Thank you. Thank you. Very nice of you. Thank you.
Thank you, sir.
Sir, thank you very much. Yeah.
Thank you.
Thanks a lot. Both of you.
We crossed double century within half an hour time, sir. Half an hour time we crossed double century participants, sir.
Thank you.
Thank you, sir. Thank you.
Thank you. Thank you.
Thank you, sir. Thank you, sir.
Bye, Suresh.
Yeah.
Thanks, sir. Thank you, sir.
Yeah.
Thank you.